So to continue our morning, I'd like to introduce Dr. Melissa Kull. Dr. Kull is a senior researcher at Chapin Hall. Her research aims to improve the systems that address family and youth homelessness, particularly in the domains of screening and withdrawal processes, and supporting systems serving children and adolescents to use evidence-based programs and resources. She incorporates mixed methods, measurement, and program evaluation expertise to support projects targeting solutions for ending family and youth homelessness and sustaining partnerships between education, early learning, and housing and homelessness system. Prior to joining Chapin Hall, Dr. Kull worked for the Bureau of Children, Youth, and Families in the New York City Department of Public Health and Mental Hygiene, which focused on designing, implementing, and evaluating mental health programs for children, youth, and families across the city. You go ahead and share screen. I will turn it over to Dr. Kull. We'll be talking about mental health trends among youth at risk for and experiencing homelessness in the United States.
Thank you, everyone, and good morning. And thank you, Anna, for that lovely introduction. So I was just going to jump right into my talk today. I think a lot of you who've spoken already have set me up nicely for this, so thank you so much. My agenda today is first to introduce Chapin Hall. We are actually Chapin Hall at the University of Chicago. You may or may not know who we are, so I'll talk a little bit about what we do. We'll discuss youth homelessness and set the context for understanding the connections with mental health. I'll talk about some of the national trends in mental health among young people experiencing homelessness. Then I'll highlight some policy opportunities. So, getting to know your neighbor, Chapin Hall, University of Chicago. We are over at 1313 East 60th Street. We are an independent nonprofit just happening to sit on the like that. Move it up. No, that's okay. We are independent of the university, but we do sit on the university's campus. We are a policy research institute, and our goal is to bring rigorous research and achievable solutions to policymakers and decision makers who are responsible for improving the lives of children, youth, and families. Our work primarily falls into three different buckets: child welfare, youth and family homelessness, and community capacity. In the domain of child welfare, we are working to prevent families' engagement in the child welfare system and to end the use of long-term foster care. In the domain of youth and family homelessness, we are working to build an evidence base as to what works for preventing and ending youth homelessness. And in community capacity, this is where we are engaging with early learning systems, after school and before school programs, and other community interventions that sit amongst people trying to improve the lives of kids and families. And really what we're trying to do is draw on communities to allow them to have active voices in what they believe would help to change their lives, and to make sure that we're bringing equity forward by identifying solutions that work and making sure that they are scaled appropriately. We are based in Chicago, but as you can see on this map in the blue, we are working broadly across the country. And so you can see we have projects ongoing in almost every state in the US, really focused on those three impact areas that I just mentioned. So I've introduced Chapin Hall. Now I want to talk a little bit about youth homelessness, and I'll focus here really on the prevalence and the predictors of youth homelessness. So about 8 or so years ago, Chapin Hall launched a sweeping research and policy initiative on youth homelessness called the Voices of Youth. This was a multi-method, multi-component study that focused on understanding how many young people were experiencing homelessness. What were the predictors of homelessness? What were the outcomes that were associated with experiences of homelessness? And what we learned is that about 1 in 10 young people between the ages of 18 and 25, and 1 in 30 adolescents between the ages of 13 and 17 had experienced unaccompanied homelessness in a given year. And this came out to about 4.2 million young people. We learned that about half of those young people who were engaged in surveys and point in time counts and in-depth interviews reported experiencing homelessness for the first time. And this really goes to show you how common and how frequent young people experience homelessness. We also learned that contrary to popular belief, youth homelessness is not more common in cities. In fact, we saw that the prevalence of homelessness for both adolescents and young adults was fairly similar across rural areas and what we would consider to be non-rural, like certain urban or suburban areas. This really points to the hidden nature of youth homelessness. Oftentimes, these are not young who come to the attention of their system, whether those are homelessness systems or school systems. They are couch hopping. They are, sometimes they are literally homeless. They don't have a place to sleep that is safe and fit for human habitation. But really, the challenge around youth homelessness is that it is so hidden and it is happening really more commonly than we would expect all across the country. We also know that youth homelessness does not occur equally across groups of young people. So you can see here on the left-hand side, these are differences by race and ethnicity, and these are findings from our Voices of Youth Count survey. About 4% of white, non-Hispanic young people reported that they had experienced youth homelessness. But when we look at other racial ethnic groups, you can see that nearly twice the prevalence of young people identifying as Hispanic and as Black were reporting that they had experienced homelessness. And when we look at Indigenous young people, that is nearly 3 times the prevalence of young people who identified as white. When we overlay experiences, or when we overlay identities and we look at the intersectional nature of these experiences, we can see that by looking at race, ethnicity, and identification with the queer community, identifying as LGBTQ+, we can see that these disparities become even more stark. So we can look and we see that white, non-LGBTQ young people, amongst that population, only 4% said that they had experienced youth homelessness. But when we look at young people who identify as both Black and LGBTQ, you can see that that is 4 times the prevalence of their white, non-LGBTQ peers. And so this really speaks to the concerns that we have about groups that are already socially marginalized and the extent to which they are experiencing further trauma and disconnection from their families and communities. So we know that some young people are also at higher risk. There are these demographic characteristics that are associated with experiencing youth homelessness. The ones that I think are really most notable here are related to educational attainment and pregnancy and parenting youth. So young people who had not completed high school were 4.5 times as likely to have experienced unaccompanied homelessness. And young people who were parenting were 3 times as likely to experience homelessness. So now I want to draw your attention, now that I've set the stage and you understand a little bit about youth homelessness, who it impacts in the US. I want to talk a little bit about the connections with mental health. So the social determinants of health framework, very commonly used in public health. And there are really 5 domains of these different types of social determinants that stand out. They are economic stability, education access and quality, and healthcare access and quality, the community context, and the built environment. And we know that the social determinants of health framework is really about understanding these larger conditions, these circumstances in people's lives that impact their health and well-being. When we think about homelessness, often we like to put it in the built environment bucket. That one typically refers to things like neighborhood or community safety, the exposure to substandard or low quality housing. But we can also think about the idea that lack of consistent access to safe and stable housing can be a really important social determinant of health. We also know that for young people, experiencing homelessness intersects with all of these other social determinants. So you saw in the previous slide that young people who did not make a lot of money were more likely to experience homelessness. Those young people who didn't finish school also more likely to experience homelessness. We know from the literature that young people experiencing homelessness have less access to healthcare, whether that's physical healthcare or mental healthcare. We also know that they have more constrained and limited social ties in their community. And so what we saw from the Voices of Youth count was that nearly 70% of young people who were experiencing homelessness reported that they had some diagnosable mental health concern. These types of things included post-traumatic stress disorder, depression, and anxiety. And it's unsurprising that young people would experience because we know that homelessness can be traumatic. The separation from family, the things that happen when young people are homeless, which can include things like greater exposure to violence, substance use. There are a variety of experiences that young people have that could result in more serious mental health concerns. And as I mentioned, access to mental care is not equitable. The literature shows us that these are young people who are resistant to engaging in care. They have greater barriers and challenges accessing that care. But I don't want this to be a fully negative presentation. I really want to underscore that these are young people who are incredibly resilient. We work with young people with lived experiences of homelessness in our work every day. We are engaging them as
Sure. Thank you.
Right?
Yeah. Thank you.
Thank you. Okay. So I was saying we are engaging young people with lived experiences of homelessness in our work every day. Sometimes this involves including them as participants in studies, but more often than not, what we're doing and what we feel really proud of is bringing them on as members of our research team. They are paid and they are considered research consultants, and they bring to bear their lived expertise in our work to make sure that it is authentic and reflects the needs of young people and their experiences engaging with these systems. And what we've seen is that these are young people who are incredibly resilient, they are innovative and creative. They are people who experience the crisis at a time when they do not have other supports to help them. And so with those supports, with the resources that I think all young people are deserving of, these are young people who have the ability to thrive and to flourish. And so, as I mentioned, youth homelessness and mental health are connected. We know from the National Alliance on Mental Illness that nearly 75% of mental health conditions emerge before the age of 24. We also know that experiencing trauma can bring on, or it can lead to the onset of a mental illness. And so here we know, clearly in terms of directionality, that youth homelessness is associated with the types of experiences that may lead to mental health conditions. We are less certain about the direction going the other way. There's not a lot of literature that helps us to understand whether youth mental health can be a predictor of youth homelessness. But in one of the presentations earlier today, we do know that young people who experience depression and other mental health conditions are more likely to be absent from school. They're more likely to disengage from school. And we know from what I've just presented before that not completing school is the single largest predictor of experiencing youth homelessness. So we do have emerging evidence of these connections theoretically and empirically. So now I want to talk about partnership between Shape and Hall and the National Runaway Safe Line. The National Runaway Safe Line is the only federally supported national communication system for young people who are in crisis, who have run away, been rejected, or are otherwise experiencing homelessness. I'll refer to them as NRS. They are actually also located in Chicago. And their mission is to keep young people, America's runaway and homeless youth, safe and off of the streets. Every year they make over 100,000 connections to young people experiencing homelessness or at risk for homelessness through both their hotline, through other online avenues that they have, as well as resources that they have to connect young people to services they support. And Shape and Hall has been working with NRS since 2020. Every year we help them analyze data from their crisis services intervention program and produce a report to their to one of their federal funders, which is the Family and Youth Services Bureau. So the research questions for this study were, what are the trends in youth mental health needs from 2019 to 2022? How did specific mental health conditions vary over time? How did mental health conditions vary by homelessness risk, age, race, ethnicity, and gender? And what other challenges were young people with mental health facing? So when young people reach out to NRS for help, they engage with their frontline staff. They don't have a structured protocol, so but they do collect relevant information into a system, and they are collecting that data through the hotline calls, through live chats, emails, and forum posts. So young people can reach out to NRS on their own behalf. They can also get calls from friends and family members, people who are concerned about a young person and want to try to figure out how they can help. For the purpose of this study, I compiled 4 years of data from those crisis intervention service connections to create a data set of repeated cross-section. Overall, there were over 130 contacts. And so this means that these are touch points with individuals that NRS frontline staff had. I think it's important to note that they are not 100% certain that these contacts are deduplicated, but they do track when families or individuals reach back out, and there's a way to like siphon those individuals off the system. So, so what I'm presenting today are individual contacts that occurred related to one particular incident or one particular person. I limited this sample to only young people who reached out on their own behalf, because I really do think that young people are the best source of information about what they need and what challenges they're facing. And I conducted a descriptive analysis that I'll walk through. So I first want to present the demographics so you can understand who's in this sample. In terms of age, you can see that more than half of the sample identified between the, more than half of the sample is between the ages of 15 and 17, with about 20% between the ages of 18 and 21, and 22% between the ages of 12 and 14. So really, the bulk of young people reaching out to NRS are between the ages of 12 and 21. NRS knows that over the past few years, young people under the age of 12 have been increasing in prevalence, in terms of increasing in the number in which they reach out for supports as well. In terms of race and ethnicity, you can see that about half of the sample identifies as white, 21% identified as Black or African American, and 14% identified as Hispanic or Latinx. And so, in line with what I was showing before, we know that young people who identify as white are overrepresented in the sample. This is something that NRS is aware of and has been working hard over the past few years to try to change their outreach methods and mechanisms so that they are actually connecting with young people who are at the greatest risk of experiencing this. And then in terms of gender identity, oh, it looks like my figure got a little messed up here, but you can see that 2/3 of the sample identified as female. So also disproportionately likely to be female in the sample. And then the 24% identify as male, and the 10% are transgender and non-binary. So how is homelessness and risk of homelessness operationalized in this data set? You can see in this pie chart, the segments that are in red are capturing those young people who are not yet homeless. So these are youth in crisis and youth contemplating running. And then those segments that are in blue are capturing young people who already reported to be homeless, which could include things like having run away or having been rejected. So overall, what we're seeing here is that this is a sample that is largely at risk. They have reached out to NRS because they are experiencing some form of crisis and they think that they will be forced to leave their homes. So given that this sample is largely not yet homeless, it's not a surprise that about 56% of young people who called NRS or connected with NRS were still at home. Not every young person revealed this information to the frontline staff, so you can see that there are quite a lot of unknowns. But beyond that, the other places in which young people reached out to NRS for support from included being with friends, relatives, or being on the street. How mental health needs are operationalized. And this, in this study, I mean, the way NRS collects information is they have this they have frontline staff, and they talk to a young person. They try to understand what challenges they're facing. And then they indicate what is the presenting problem. So a presenting problem could be lots of things that often show up in this data set include like family dynamics, economics, transportation. These are things that young people need help with. They can also indicate mental health, and they can sort of drill down to specific needs, which I've listed here on this screen. So you can see that amongst this sample, 15% said that they were experiencing depression, and that was one of their primary presenting problems. Beyond that, about 7% they were experiencing suicide, and 6% said that they had some other behavioral or psychological issue. Then you can see that there are some less common mental health needs, including things like having a family or a friend who's struggling with something, or being a victim of crime or witness to crime. I want to note that these figures are low compared to what we've seen earlier in some of the previous talks. And what's important to remember here is that this is not like the data that this program collects. It's not a survey of young people experiencing or at risk of homelessness. These are young people who are experiencing a crisis, and they have identified what they think is that major source of their crisis. And so it's likely, I think it's almost certain, that these are an underestimate. These are a very conservative estimate of the types of mental health challenges that we know this population is facing. So as we walk through the findings, I'd urge you to look more at the trends and less at where we are in terms of percentages. So I want to note that in some of these analyses, I combined all these mental health conditions together, and I looked at mental health overall. In some of them, I combined depression and youth behavioral and psychological issues together, so we can kind of drill down and look a little bit more closely at specific mental health conditions that emerge. And so you can see here that about 18% of young people in this sample overall reported that they were experiencing depression or having some other kind of behavioral or psychological issue. And then amongst those young people who said that they were experiencing suicidality or self-injurious behaviors, this includes about 9% of young people overall in this sample. So on this slide and on all the subsequent slides that I'm going to show from this study, I want to orient you to how I've set this up so you can understand what I'm demonstrating here. So on the y-axis, we have the percentages, and these are the percentages of young people who, when they reach out to NRS for support, indicated that mental health was one of their primary presenting problems. On the x-axis here, we have time. So you can see the years over that from the data set that we've compiled here, and for each of those numbers above the years, those are simply the month. You can see here that this shading in the middle is capturing the time from when the pandemic started to approximately when vaccines became more widely available. So on this slide, you can see in the red bar, these are young people who are reporting mental health concerns, and these are overall mental health concerns. And you can see that there's like a slight tick up. It's pretty, I wouldn't say it's like pronounced. It's not nearly as dramatic as some of the other graphs we've seen today, but you can see it's a pretty positive, like linear relationship here. But as we look coming down towards the end of 2022, we can see that mental health concerns really are leveling off and have receded to pre-pandemic levels. When we look at specific mental health conditions over time, you can see that in the blue, we have current and past suicidality and self-injury, and there's really not a lot of change here. Surprisingly, this is, I think, somewhat in contrary to some of the other presentations we've seen this morning. But we do see a really notable increase over the course of the pandemic, which includes lockdown and the time when, people didn't feel like they could interact or be together, which we know is a particularly challenging time for young people in particular. So here for depression and other behavioral psychological concerns, we do see that pretty sharp increase over time. And again, kind of dropping off here to the end of 2022. When we look at young people who identify as homeless versus those who are at risk for homelessness, we see some surprising findings here, and I want to note that the trend lines for homeless are a bit noisier because these groups are much smaller, right? Or this group is much smaller than the group that's at risk for homelessness. There's only 20% of the sample in the group that identified as experiencing homelessness actively when they connected with NRS. What you can see here is that, somewhat surprisingly, those young people who were already homeless are reporting lower rates of mental health concerns than were young people who are at risk for homelessness. And I think the interpretation here that's most important to keep in mind is that young people who are homeless have pressing basic needs issues that they need met. And so it's likely that when they reached out to NRS, they are looking for things like transportation, support getting resources like reconnecting to their families. They are looking for an opportunity to stabilize themselves. Whereas those young people who are at risk for homelessness, those are not yet concerns for them, but they are dealing with something inside of their families, inside of their homes. And it's possible that depression and other mental health needs are associated with this increased likelihood for being at risk for homelessness. So it's not to say that those young people who are homeless are not experiencing mental health concerns. We know that they are from all the literature. It's that those are not listed as their primary presentation. When we look at differences by age over time, we see that those young people identifying as being between the ages of 12 and 14 are experiencing the highest levels of mental health concerns, followed by young people ages 15 to 17. And you can see that their trend lines are fairly similar. For those young people between the ages of 18 to 21 over time, not a lot of change, like a slight increase, I would say, through the course of the pandemic, but really like not quite as notable as the younger people in this sample. For race and ethnicity, this is hard to look at, so I did drill this down, but I wanted you to see everything together. I do present these more one-to-one comparisons. And so first, on the left-hand side here, looking at Asian, Hawaiian, Pacific Islander versus white and Caucasian. And again, these trend lines are pretty noisy. I'm presenting these findings by month. So as these groups get smaller, the trend lines do get noisier. But you can see overall here for Asian, Hawaiian, Pacific Islander compared to white and Caucasian, trends are fairly similar. We see this rise during the course of the pandemic, and we see a drop off after time. Ultimately, Asian, Hawaiian, Pacific Islander young people reported lower levels of mental health concerns by the end of 2022. Comparing Black and African American versus white and Caucasian, somewhat surprising findings here with young people identifying as Black and African American, indicating lower levels of mental health needs or concerns over time as compared with white and Caucasian young people. But again, really seeing quite similar trend lines, just a slight difference in the prevalence of mental health concerns at all of these. For the comparisons, looking at Hispanic and Latinx versus white and Caucasian and multiracial versus white and Caucasian, really seeing very similar trends over time. A lot of noise in the multiracial group because that group is much smaller. But you can see that if you kind of like eyeball it, that the trends are really looking fairly similar over time in terms of like this increase during the pandemic, during like the height of the pandemic, and then a sort of like slow drop off. So this figure shows the differences by gender. You can see in the light blue, young people identifying as transgender and non-binary. And then in red, females, and in dark blue, we have males. I think what's notable here and what aligns with the literature is that young people identifying as transgender and non-binary are reporting the highest levels of mental health needs over time. It does like increase, their needs increase over the course of the pandemic, and they continue to stay higher than young people who identify as female or male. The females and males do seem to have quite a similar trend line over time, with females reporting modestly higher differences than males, modestly higher mental health needs. So now I want you to think about, I want to share with you what other needs young people experiencing or at risk of homelessness and experiencing mental health needs reported. So it wasn't a mutually exclusive choice to report a presenting problem when they connected with NRS. So they could also indicate what other challenges they were facing. And I think what really resonates with what we've heard today, and it should not be surprising, is that 92% of these young people said they were experiencing or at risk of homelessness and experiencing mental health challenges, said that they had issues in their family dynamics. 53% of these young people, more than half, said they were experiencing emotional abuse. 23% that they were experiencing physical abuse, and 18% said they were experiencing neglect, showing that there's a real issue with abuse and violence and neglect and maltreatment. And then there were also 24%, or about a quarter of this sample said that they were experiencing issues in their sort of peer and social environment, which could include things like friendships or gang involvement. So, I mean, what really jumps out here overall is the overlap between mental health needs and family dynamics. So I want to leave you with a couple of key takeaways from this finding. The first is that depression and suicidality. Oh, I'm done already? Oh, I 30 minutes. Can I have like 2 minutes to talk about the policy solutions? Okay. So I did want to share some information about policy solutions. You can deduce the takeaways. I wanted to share a little bit about policy solutions, which I did want to present from a housing and homelessness lens. And folks have talked about triage, the importance of triage. We know it's important in health systems. We know it's important in housing and homelessness systems. But we also know that it's insufficient. So when we think about housing and homelessness systems and the services that are available, we can think about the service continuum in this figure here. So we have prevention, we have entry points and shelters and transitional housing, which we consider as the crisis response, and we also have stable housing. So this is the traditional focus of policy and public investment really sits in this crisis response. Basically, young people have to be homeless in order to get access to services, and that isn't working, and it has to change. So if we think about this is the service continuum, these are the services that exist for young people. We know that the prevention and stable housing buckets here are actually quite a lot smaller than they are demonstrated here on this slide. But if we think about this is where the services are, we have to ask ourselves, where is it critical to embed mental health supports for young people who are experiencing or at risk of homelessness? And the answer is everywhere that these young people are showing up in the system. And so what would that look like? There are various different ways we can think about this. I'm happy to talk more about these things. I mean, this is like the crux of my policy talk here, but I can do more of this during the Q&A. But we have to think about prevention. We have to think about screening in schools. We really need to be leveraging schools as opportunities and places where lots of young people exist, where they have engagement. And so this is the place where we can do screening, and we can also find ways to do some co-navigating, having mental health consultants based in schools. I've worked on prevention projects in both of these domains, doing both screening and supporting mental health consultants, and I'm happy to talk about those. In terms of the entry points, which we think about as like drop-in centers for youth experiencing homelessness, this is where, again, we need screening with valid and reliable tools. We need to make sure these young people are getting triaged and connected quickly and appropriately to the services that they need. In both entry points and shelters and transitional housing, we really need to have more co-located counselors and mental health clinicians, because this is where young people get lost in that warm handoff process, in the referral they don't feel comfortable with. And so if young people can have a one-stop shopping experience, getting access to the services they need and the housing supports that they need, they're much more likely to take up those services. In terms of permanent housing looks like a lot of different things. It can look like a long-term rapid rehousing project. It can look like a housing voucher on the private market. It can look like permanent supportive housing, which is housing assistance mixed with supportive services for young people with certain needs. There's an opportunity here to engage young people in aftercare programs to ensure that they are getting some kind of case management for both their mental health needs and their housing needs. And so I just want to take a step back. I've really tried to focus on, and thank you all for giving me this extra time because I'm really so separate. I've talked a bit about how we can connect mental health services to the housing and homelessness systems that exist in our communities. But I also want us to take a step back and think a bit about the social determinants of health framework that I presented earlier, right? We know that there are these systems, these structures, they create conditions in our lives. They impact our communities, they impact our families, they impact individuals. I've worked in a public health department. I know how much time, energy, money goes into making sure that there are supports for individuals to make sure that they have access to the mental health services that they need, make sure that those services are accessible, that they're culturally responsive, and that they are meeting young people and families where they are and using a strength-based approach. But I would encourage us all to start trying to figure out how we can paddle upstream. How can we figure out how to not just make these services available, but to my points presented here in my talk, and to the other points we've heard this morning, how can we figure out how to strengthen families, invest in communities, and create equitable systems and structures so that these investments at the individual level are not needed to the extent that they are right now, especially given all of the mental health needs facing in this country today. So I'll stop there. Thank you for giving me so much time, and I'm happy to answer your questions.
So much, Dr. Kull. Okay. I think we've got time for one question. Right over here.
Allie Sontag, I'm a nurse practitioner at the Chicago Department of Public Health. Before I worked in public health or in schools, I, was a provider, and I think there's a few things that we don't do a great job at. It's education on the McKinney-Vento, right? The educational rights of students who are experiencing homelessness, and also the unaccompanied minors rules for those who are over the age of 14 in Illinois to access healthcare. So how do we get those messages out in communities that aren't necessarily hearing the message to better service our youth in those spaces?
It's a great question. And so the question was about how do we better educate folks in the community to make sure that young people experiencing homelessness who are interacting or engaging with different systems or services know what their rights and opportunities are. And I think it requires a considerable amount of training and technical assistance to community providers. So for federally funded runaway homeless youth grantees, which are youth service providers who are interacting with young people experiencing homelessness in a variety of different types of programs, they get access to a federally funded training and technical assistance program. But there are lots of other service providers in our communities who don't get that kind of TTA that I think would be really useful. And so this is where I think at an individual community level, we need to start taking responsibility for making sure that folks know, young people know what sort of services and resources are available, having sufficient education amongst different navigators inside of these systems, whether it's like the McKinney-Vento liaison or whether it's other folks at pediatricians' offices or doctors' offices or clinics. There needs to be more coordination and support amongst all of these different providers so that when young people experiencing or homelessness do engage, that they can quickly figure out where they need to go and what sort of services they have access to and what their rights are. But yeah, it's really difficult when we have these patchworks that don't talk to each other.
Thank you so much, Dr. Kull.
Managed to get the cord stuck on something here, so awesome. Thank you, Dr. Kull. I'm excited to next introduce our keynote speaker, Dr. Samira Bora, who's